I thank Miom Academy for giving this opportunity. So I'll be talking on regimens like PRN versus treat and extend in the treatment of diabetic macular edema. So as you all know, diabetes is a worldwide which is increasing everywhere. Almost 700 million individuals can be there at around 2045, and central involving diabetic macular edema will be the most common leading cause of vision loss in the diabetes, and has right now anti-VEGF is the main line of treatment for these conditions. So treating these conditions with a diabetic, it's a very chronic disease and it has a multiple systemic concurrent systemic illness. These people require multiple injections which can be required, and most of the patients they require bilateral injections. So the treatment cost, what all the regimens which are there, with the landmark trials which they did with the ride and rise trial and all. So that is a fixed regimen and that costs very high cost, which involves both the drug cost and also the physician remuneration. It also involves the indirect cost of stress, the having patient has to go, the travel, everything which includes. So as the severity of the diabetes increases, the cost of the burden also increases. So now we are looking for alternate regimens which will help for that. So I will be talking about which may be the better, whether it's a treat and extend or a PRN approach. So what is the treat and extend approach? Usually the treat and extend approach means we'll be doing a loading dose of 3 injections first. Later we'll be extending the duration, and every duration whenever the patient visits the clinic he will be injected. So usually we initially started by 4 weeks, then we'll increase it to 6 weeks or 8 weeks. And then the macula is dry, we will be continuing that 8 weeks visit, and that time whenever the patient visits the hospital he will be injected. And if again there is a recurrence of the macular edema, we will decrease the duration of the visit. Similarly, the PRN approach, whenever the fovea has a fluid, so that time we are going to inject following the loading dose. And if there is an active fluid, we will be injecting. If it's not, we will be calling the patient monthly once, and we will be doing a OCT and the clinical assessment, how is the situation. Based on that, we will be injecting the injection. So like various trials has been done to see which regimen is better, whether it's a PRN approach or a treat and extend approach or a fixed approach. And the latest injection which has come, also the aflibercept, also they have done the trials to see which is there. Let me go through certain studies. The most important trial which went through is the retain study, where they looked around whether the treat and extend of ranibizumab injection with or without laser and the PRN approach, which is better at the primary endpoint of 1 month, 1 year and 2 years. And the study showed that most of the cases there is no clinically significant, there is not much difference in the mean change in the best corrected visual acuity or in the mean change in the central foveal thickness. Being with the laser, it may show the central foveal thickness is the least one, but also the visual acuity wise there is no much difference which has been seen. And what they had told is treat and extend over a period of 2 to 3 years. After the first or second year, the number of injections required may be less, and the indirect cost, because in the PRN where they want to come monthly visit, in the treat and extend the number of visits are less, the overall burden may be lesser. Similarly, one more real world evidence of trial done by Abnetar et al., where they checked with a visual acuity based PRN approach or a OCT based treat and extend approach, and for the 1 year they saw there are no much clinically significant difference in the visual acuity in the both groups. And when the group with the visual acuity associated PRN approach, they required slightly fewer injections, around 5.9 per group compared to the OCT associated treat and extend approach. Another trial which has come with a violet trial based on the aflibercept injection, where they randomized into the fixed dose treat and extend approach and the PRN approach. And in this study, what they showed is like both treat and extend and the PRN approach gave the similar functional outcome compared to the fixed dosing, even in the second year and third year of the treatment. And after the second year, the treat and extend patients required lesser number of injections compared to the PRN approach. The most important systemic review came by Saraya et al., where they did the review of all the studies, and almost 2,346 eyes they reviewed, and what they saw, the treat and extend is similar to the fixed and PRN regimen with regards to the visual acuity and the anatomical outcomes at both at 12 months and 24 months. Visual acuity outcomes are essentially equivalent for both treat and extend and PRN approach. And what they show in multiple studies, the PRN required lesser injections compared to the treat and extend and fixed regimen. As I told you, there are various studies are there, and there is a mixed approach where some studies says treat and extend is better, while others says PRN approach is better. So we just did a small retrospective data where we saw for the 12 months data how is in the my clinic, how it goes on, and around 30 patients I looked into that which is doing better, and almost the age group everything is considerably both together, and number of injections what was required in the PRN approach was lesser compared to the treat and extend approach, which was around 7.9. The baseline best corrected visual acuity gain was slightly better in the treat and extend compared to the PRN, but it was not clinically significant. So here also showing the mean how much is the best corrected visual acuity and the central foveal thickness. So this is a one patient with a 60-year-old male with a complaining of blurring of vision. He has underwent multiple injections where he received initially loading dose of 3 injections. Then if you see the patient required in a year 1 or 2 injections, I kept him under PRN approach. So he received an injection after 1 year at 20th of February 2024. Then he received after 1 year he required only 2 injections, and still he is maintaining a good vision of 6/9 with only hardly in 2 to 3 injections in a year. But similarly, this is another patient who required treat and extend approach, because soon as we stopped the injections or we are extending 2 to 3 months, he was requiring injections. So I kept him under treat and extend, where every 6 weeks to 2 months I am injecting him continuously from the last 2-3 years. So what are the advantage of PRN? So it requires slightly comparatively lesser injections, the cost and risk is bit lesser, and it is a patient tailored plan compared to the treat and extend. But the only disadvantage is, yes, sometimes we may not be knowing that when the patient develops edema, and the patient visual acuity may become lesser compared to the treat and extend, where we are keeping the fovea dry continuously. The recurrence chances in the PRN approach is more, because sometimes the patient may not come for a proper follow-up and anatomical instability can happen, and once the fluid recurrence happens, the structural changes in the retina can happen, which may lead to the decrease in the visual acuity later.
Can you open the presentation, please?
Yeah. So which is the one to go ahead with? It's mainly a tailored based approach. So if the patient can able to come for a frequent monitoring and the visit doesn't cost more to the patient, then it's better to keep a PRN approach. And if the patient is not able to come and he is having unreliable follow-up and every visit costs him a lot, keep him under treat and extend approach. Look for the baseline visual acuity, the OCT biomarkers like a drill or how is the ISOH junction, and then reassess. And if you are continuing one regimen, reassess after 6 to 12 months and see whether it's working or not. If it is not working, you can switch the regimen also. So the regimen choice should be guided by the visit and injection burden, monitoring logistics, and the patient preference. Thank you.
Thank you, Dr. Sharat. Any question for Dr. Sharat? I totally agree with you. PRN, I think PRN is less costly for our patient, less injection. But once you cannot get the patient back, I think treat and extend. I used to do that in the COVID. I always use PRN. But in the COVID area, I did treat and extend because I lost a lot of patients. They came back with aggressive diabetic macular edema, hard X's. I could not retrieve the vision when they left me. So again, if you are not trusting the patient or the patient cannot be compliant, treat and extend will be good, but again, PRN is the best because it's trusted. I mean, once the patient in and he had fluid, you can start injecting him. And I think diabetic macular edema, as we always say, completely different from neovascular AMD. It's a forgiven disease. Once you control the diabetes, once you are strict, sometimes you can control that and you will never have to be injected every now and then. But it's the opposite in neovascular AMD. That's why PRN is mostly the most preferred regimen in these cases. Thank you so much. Thank you. The last presentation is mine. It's about EI versus traditional imaging in diabetic macular edema. Before I start, I need